Hello everyone, and thank you for coming along to this introductory webinar on artificial intelligence in nursing from the AI Nurses Network. I will be covering some of the key concepts on AI and their applications in nursing, which I hope you find useful. My name is Siobhan and I'm a senior lecturer in the nursing faculty at King's College London and adjunct associate professor at Western University Canada, and I was recently appointed as a liaison to the United Nations by Sigma Nursing. I have a background in informatics before I became a nurse, so all my teaching and research is on technology and healthcare. And now that artificial intelligence is an important and growing area within informatics, I'm starting to work in that space as well. Some colleagues and I set up the AI Nurses Network recently with the help of funding from the Burdett Trust for Nursing, and we aim to provide a range of resources and opportunities for nurses to undertake clinical research on AI to improve patient care and population health. We have a dedicated website where you can access all these resources as well as sign up to our monthly newsletter. We also have an active LinkedIn group where we share extra materials on AI on a regular basis, as well as our YouTube channel that hosts these webinars. So today's webinar is just a brief introduction to artificial intelligence, as it's a huge field. I'll start by talking about where AI has come from, and then I'll discuss the main domains and techniques in the field. And that will bring us nicely along to how artificial intelligence is being used in nursing and how nurses can contribute to this new technological trend. Before I start, I want to give a nod to Florence Nightingale. She is most famous for her work on infection control during the Crimean War, but she had a background in statistics before she became a nurse. And that mathematical background was instrumental in a lot of the pioneering work she did throughout her life, including her work on infection control. So she's often referred to as the world's first nursing informatician. And no doubt if Florence were here today, she would be the leading light in relation to AI in nursing. So starting with some background in artificial intelligence, it's a very big field that develops and applies advanced computational techniques to digital data. And AI has many areas within it that look at different aspects of human intelligence and try to mimic it using software and hardware. So AI could look at anything from abstract reasoning to learning, decision making, communicating, or interacting with the virtual or physical world around us if you're into robotics, chatbots, or gaming. There are a lot of definitions of artificial intelligence describing what it is and what it isn't, and even in the field of computer science, there's no real agreement about what AI is because people interpret it in different ways. But I quite like this description from an EU report that summarised and synthesised many definitions of AI, as it's quite detailed without being too technical. It takes account hardware and software and the different application areas of AI, and it talks about how AI can use symbolic rules or predictive modelling, because there are lots of different forms of artificial intelligence. It's not just one particular technique in one application area. So I think that definition is quite useful to work from, and no doubt it will change over time as AI develops and changes in the future. So artificial intelligence began way back in the 1950s after the end of the Second World War, when breakthroughs by Alan Turing and others in computing and encryption inspired people to explore AI. Marvin Minsky and John McCarthy, who both worked at MIT in the United States, are considered to be the founders of the field because they organised a series of meetings and then conferences in the mid-1950s and beyond that started research into AI. But it didn't really take off until much more recently because there was lots of experimentation and dead ends in the 60s, 70s and 80s. And it wasn't until the early 1990s when advanced computational techniques like machine learning and natural language processing started to emerge. And since then, the field of AI has been expanding rapidly. Interestingly, you'll find AI being applied in nursing as far back as the early 1990s. The example on the slide is from a nurse called Rose Harvey from Boston College in the USA, and it's one of the earliest research studies that I found when searching. But I wouldn't be surprised if there were studies going back into the 1980s as well. It's just more difficult to search for research the further back you go, because the language around AI has changed and various journals and conferences have come and gone. But even way back then, some nurses were really on the ball in terms of informatics, and the rest of us are just catching up 30 years later. There are many different areas within AI, such as fuzzy logic, expert systems, Bayesian networks, etc. But just for this webinar, I'll talk about the two main areas because they are the most popular and widely used techniques. So the first is machine learning, and these are all the algorithms that are used to learn from past data to build predictive models. And the second is natural language processing, or NLP. And as the name suggests, it uses software techniques to understand text or voice data. The other thing to be aware of is that AI also overlaps with neighbouring fields like data science, text mining, and good old-fashioned statistics, because they share some techniques in common. So it can be a little confusing and messy when you start reading about AI, as you'll probably come across these fields as well. So the main set of AI techniques are called machine learning, and as I mentioned, these are all the algorithms that are used to learn from past data to build predictive models. The algorithms are grouped into three categories, which are supervised learning, unsupervised learning, and reinforcement learning. I'll briefly go through each of these and give you some practical examples from healthcare. The most popular set of machine learning techniques are supervised learning, and this is how they work. You have an electronic dataset and you need to annotate or label a subset of that, which is called the training dataset. The labels are associated with specific features or characteristics in the data, which are labeled by a human expert. Then you select one or more supervised learning algorithms, which could be things like a decision tree, random forest, support vector machines, etc., which all work slightly differently in terms of how they analyze data. But regardless, the algorithm builds a mathematical model based on the labeled data provided and the known outputs, and learns the rules or trends it finds in the training data to produce an output. Then you apply the algorithm to the test dataset to generate the final predictive model or output. And now it's quite popular to have a validation dataset as well as a test dataset. So that's why these techniques are called supervised learning, because you tell the algorithms what to do to some degree by labeling the dataset and knowing the output that you're expecting to get. So this is a practical example of how that works in healthcare. A decision tree is the simplest supervised machine learning algorithm and one of the most popular, and it's good at handling classification and regression tasks. The diagram is taken from a research study by Herdez et al. And helps to visually explain how it works. It's a hierarchical tree-like structure which has a root node at the top, internal nodes or decision points, and leaf nodes at the end. So the algorithm splits the data in a top-down recursive way until all or most of the electronic records have been classified under the specific class labels or leaf nodes at the end, representing all the possible outcomes. This example is from a Canadian research team who developed and validated an AI algorithm to prioritise access to care home services for older people. They created their own decision tree algorithm called Maply for that specific purpose, and this is what it looks like. And they used a dataset of over 4,000 older adults to identify predictors for nursing home placement. Then they created a computerized decision support tool based on this algorithm to help case managers identify people at risk or at higher need of care home services, so they could prioritize older people who needed support more quickly and provide that instead of an older person deteriorating at home or ending up in a hospital for weeks or months when they should have gone to a care home. And the link is on that slide that will take you to the full paper, which is open access, and explains how they did that in a lot more detail. And that was just a visual representation of how a decision tree algorithm works. What it looks like in reality is more like this. A lot of code, because the two main programming languages that are used in AI are called Python and R, although there are others like Julia, Scala, and good old-fashioned Java, C++, etc. And just to say that any AI technique has its advantages and disadvantages. So a decision tree, the obvious benefit is its simplicity. It's easy to interpret, little or no data preparation is required, and it's very flexible compared to other algorithms. However, some of those things are also a drawback, because if you have a large complex data set and very complex decision making, then it's not much good to you because it's too simplistic. And it's also prone to overfitting when it moves from running on the training to the test dataset. Another very popular type of supervised machine learning technique that I want to touch on because it has huge applications in healthcare is called an artificial neural network, or it's more commonly called deep learning, where data is processed through layers. As you can see in the visualization, the algorithm is comprised of layers of nodes containing an input layer, one or more hidden layers, and an output layer, which is why it's referred to as deep learning. So each node or artificial neuron connects to another and has an associated weight and threshold. If the output of any individual node is above the specified threshold value, then the node is activated and it sends data to the next layer in the network. Otherwise, no data is passed along. And because there are so many layers to neural networks, it's not possible to tell which variables in the dataset the algorithm uses to arrive at the final predictive outcome or model. So they're often referred to as a black box. And just like any supervised technique, they rely on training data to learn and improve their accuracy over time, helping to classify and cluster large volumes of data at high speed. So they're very useful in healthcare, particularly for image recognition software in radiology, and they're also used a lot in speech recognition systems. Just to note that there are different types or configurations of neural networks which are used for different purposes, depending on the data that you have and the type of complex modelling that you need to do. So there isn't just one standard approach. Ones you might come across are perceptrons, multi-layer perceptrons, convolutional neural networks, recurrent neural networks, etc. This is a nice example of how a neural network was applied in healthcare to improve the accuracy of diagnosing skin conditions in primary care. This research team developed a web-based tool and used photographs of skin conditions and the corresponding medical history of patients to build a predictive model based on a neural network. And the aim was to improve outcome prediction for hundreds of skin conditions in primary care where there isn't a lot of expertise in dermatology. The link to the publication from Jane et al. Is on the slide, and it's open access if you'd like to read it in more detail. They have a data set from over 16,000 cases to train the AI model, and then they asked 20 primary care physicians and 20 nurse practitioners to review a subset of those patient cases, with some using the AI web tool and others the standard approach reviewing patients' medical records to compare the two. And they found that when using the AI tool, clinicians were able to identify skin conditions more accurately, which corresponded to a benefit for 1 in every 8 to 10 cases, which isn't a massive improvement, but it's a good way to apply neural networks in healthcare. Then the next category of machine learning is called unsupervised learning, and these algorithms work differently because they're used to analyze and cluster unlabeled datasets and discover patterns or data groupings without the need for human intervention, which is why they're referred to as being unsupervised. These algorithms are used for different types of tasks, which include clustering, association, and dimensionality reduction. And that's about reducing noise or variance in a dataset if it's too big without losing the integrity of the data. So they are more about descriptive modeling and telling you what patterns, groups, or relationships are in your dataset rather than trying to predict things. And again, there are lots of different unsupervised machine learning algorithms, and k-means clustering is a common one, where the key variables or characteristics in the data are assigned into a number of groups or clusters based on the distance from each group centroid. So the example on the slide is from a team of nurses who developed a patient classification system that stratifies patients admitted to intensive care based on their disease severity and nursing workload. They extracted data on 300 critical care patients from their hospital's electronic medical record system, and then used a number of AI techniques, including k-means clustering, to assign patients into 3 subgroups using 16 different characteristics, 8 of which were related to disease severity and 8 about nursing workload. And you can see those on the graph. I've just taken the figure directly from the Anne et al. Paper, and again the link is on the slide if you want to read it in more detail. But you can see each of the groups are quite different, with Group A having the highest disease severity and needing the most nursing care because the patients are on mechanical ventilation. So this approach could be used to help nurse managers identify similar patient groups who have specific care needs and then assign nursing staff according to their levels of clinical expertise to improve the management of critically ill patients. But of course, like any AI technique, it needs good quality data to work well. And finally, the last type of machine learning is called reinforcement learning, and this is quite different because it focuses on optimizing sequential decision making when the decisions are repeated over time and when they occur in a dynamic or changing environment where there's some level of uncertainty, and that really mimics the real world. So reinforcement learning works within a mathematical framework consisting of 3 elements, which are the state space, and that's the available information or the problem features that you have to work with. Then the second is the action space, which are the decisions that you take at each state of the system. And the third is the reward signal, which is the feedback about how the agent or algorithm performed, and that can be positive or negative. And you might also include things like system constraints and uncertainty into your model. So it's really akin to learning by experience, and we'll look at a practical example on the next slide. But reinforcement learning is used a lot in robotics, self-driving cars, and chatbots or generative AI tools like ChatGPT, etc. And like before, there are lots of different reinforcement learning techniques like temporal difference, Q-learning, Monte Carlo methods, etc. And they all have their advantages and disadvantages like any AI technique. So this is one example of how reinforcement learning has been applied in healthcare. This research team developed a digital intervention to encourage women to attend mammography screening, and it was based on reinforcement learning techniques. Over 100,000 women were sent regular emails over 2 years to encourage them to attend for a mammogram, and the AI algorithms were used to personalise the email content and use behavioural nudging to encourage attendance. And you can see an example of that on the right hand side in terms of the emails the women got, and the link to the published research study from Boucher et al. Is there if you want to get more information on it. And on the left you can see they would email groups of women for 4 to 5 months at a time, then take a break and start again. And over time the algorithms optimise the message composition based on the women's past behavioural responses, such as opening messages, clicking calls to action, and scheduling and attending mammograms. Then it selected various content to put in emails to maximise the probability that the recipient would complete the target behaviour. The research team didn't look at the effectiveness of this and whether it worked or not. The study was just to assess how feasible this approach was to set up, but presumably there's a clinical trial in the pipeline that will look at efficacy, and hopefully it does improve attendance at mammography screening. So that's one interesting application of reinforcement learning in healthcare. The other domain in AI that's quite popular is called natural language processing, which uses software techniques, mainly symbolic rules, things like tokenization, part of speech tagging, etc., to understand and respond to text or voice data, particularly large unstructured datasets. So NLP uses a combination of computational linguistics or rule-based modeling of human language with traditional statistics, and it can also use machine learning, in particular deep learning models, to process human language, whether it's audio, written text, or both, to understand what it means. And this is a nice application of NLP in healthcare, where a research group in the United States extracted unstructured free text data such as notes from physicians, nurses and social workers on over 800 children from an electronic medical record. And they extracted the data before the child was referred to the child protection team to try and identify which ones were at risk of or victims of physical abuse to improve screening and speed up referral. The figure is from the research paper by Anna Pragada et al., which you can access via the link on the slide. So they use 3 NLP techniques called bag of words, word embeddings, and rule-based to train multiple neural networks to detect cases of likely child abuse. As you can see, they trained 8 or 9 different models to see which one will be most accurate and reduce the false positive rate. And now that they've done this, they want to take the best performing model and develop a computerized platform to speed up and improve the accuracy of screening and referring children to child protection services. So that's a great application of NLP. Now that we've covered the main domains within artificial intelligence, let's have a look at what's happening with AI in nursing. Some colleagues and I did a systematic review recently to help answer that question, and I'll go through what we found with you. We had 3 research questions underpinning the review, which were how involved nurses were in AI research, what areas of nursing was artificial intelligence being employed in, covering clinical practice, education, research and policy, and then what were the benefits, limitations and risks of AI. We used a standard approach and developed a search strategy covering the key terms and ran those on a number of databases using a 20-year timeframe. We excluded studies where AI was under development, simulated, prototyped, or not applied to any real-world dataset or scenario, or where any specific AI techniques were not described in some detail. And we also excluded the usual conference proceedings, theses, discussion articles, and grey literature. We did find a couple of other reviews of AI in nursing and extracted studies from those to include in ours. We ran our search in July 2021, so it is a little bit out of date now, but we found just over 2,000 studies, and after screening we ended up including 140. We didn't undertake any critical appraisal because the studies were quite technical in nature and the usual checklists wouldn't really apply, and also the review was non-funded and we were trying to get it done over the summer in between teaching semesters, so our resources and time were limited. So instead we ranked the studies according to the journal's impact factor as a rough proxy for quality, which I appreciate isn't a perfect metric to use. And then after extracting data, we summarised studies in a descriptive way because most were quite technical, so a meta-analysis or some type of narrative synthesis wouldn't have worked. So it's quite a descriptive review, but hopefully it's a useful starting point to understand how AI is being applied in nursing. In terms of the results and the study characteristics, the majority of studies were conducted in the Americas, with 65 from the United States, 10 from Canada and 2 from Brazil. Quite a few studies, 39 in total, were from the Asia-Pacific region, with research groups in China, Taiwan, Japan, South Korea, Australia and Hong Kong. There were a small number of studies from Europe, only 21 in total, from a whole range of countries including the UK. And then there were 3 studies in the Middle East from Iran and Saudi Arabia. There was one multi-centre study which included data from 9 countries, one of which was Ghana in West Africa, but other than that there were no studies from the continent of Africa. As you can see, there's been a huge increase in the number of research studies over the last few years across all regions of the world. Some of the algorithms do go back into the 1990s, but there are many more algorithms now and they're much easier to apply than they were previously. And alongside that, computing power and storage capacity has increased massively during that time, making AI research more doable, and there's more funding available, hence the rapid increase in the number of studies over the last few years. And I'm sure the COVID-19 pandemic helped as well, and my guess is that that trend will continue. The study designs were primarily quantitative in nature, using retrospective cross-sectional or cohort designs, but a few studies did use mixed methods or qualitative approaches. Datasets from electronic health records in hospitals were most commonly used, with a few using community-based datasets from care homes, universities or home care settings. The most common algorithms were things like decision trees, random forests, neural networks, but there were many more algorithms reported because there's a lot of computational techniques in AI. So our first research question was around how involved nurses were in AI research. We found about 1/3 of studies were actively led by nurses who were the corresponding author, which is encouraging to see. Those not led by nurses came from different disciplines such as computer science, engineering, medicine, medical informatics, and a few were led by commercial companies like Google who were active in the AI space. There were a smaller number of studies, about 7%, where nurses actively participated in the research by providing clinical expertise to validate the results of an AI model and whatever predictions it was making. Then there were a smaller number of studies, about 15%, where nurses took a more passive role in the research by providing some or all of the dataset for analysis, or they assisted with the implementation or use of an AI-based technology in a healthcare setting, but they didn't actively contribute expertise to the development or validation of the AI techniques, models, or systems developed. So that's how we differentiated between being actively or passively involved. And then finally, in quite a few studies, nearly half, nurses did not take part in the development, implementation or use of AI, but they could be potential future users, which is why we included those studies in the review. I won't go through specific examples of those studies, but there's a lot more detail in the published review. And just to note that the journal we published in only allowed a maximum of 50 references, so we couldn't cite all 140 studies, but we referenced as many as we could. And you'll find a summary of all the study characteristics and the DOI link for each one in the supporting files, and they're available to download from the journal website if you want to track down any. Our second research question then was about how AI has been applied across the nursing profession. The vast majority of studies were related to some form of patient care, with the most common clinical areas being critical care, general nursing care, wound care, infection control, older adult care, hospital readmissions, midwifery, emergency care and hospital discharge. About 15% of studies were related to nursing administration and management, so that was things like how AI could improve data quality or written nursing notes, and a few studies looked at how AI could predict nurse staffing in acute settings, burnout among nurses, their job performance or levels of bullying. There were only 4 studies related to nursing education, and they used AI algorithms to predict student attrition from nursing courses, academic failure rates, graduation and completion rates, and there was one study about how nurses could learn to use an echocardiogram using AI-assisted software. We didn't find any studies on AI being applied in the research process itself or in the policy arena, but I'm sure they exist now a couple of years later. Again, there are more practical examples of those published studies in the published review. Our third research question then focused on the benefits, limitations and risks of artificial intelligence. So firstly, looking at the benefits. Most of the studies reported potential benefits because they only developed and tested AI algorithms or gauged people's perceptions of them. They weren't actually used in the real world with practicing nurses to inform decision making and care delivery, but the algorithms were tested on real health datasets. A very small number of studies, about 12%, implemented an AI-based technology in a healthcare setting that was used by nurses and reported some benefits. But the quality of those studies varied, and some had quite weak study designs, so the reported benefits are probably a bit questionable. But overall, the benefits reported, whether potential or actual, included increased accuracy in predicting health, education and other outcomes, or identifying variables that would affect outcome prediction in the models that were developed. Then a few studies reported potential improvements in nursing documentation and data standards, the management of nursing staff, triaging patients, making clinical diagnoses or monitoring patients and their environment. And again, more specific examples of the benefits of AI in nursing are in the published review. When we looked at the limitations of artificial intelligence, they mainly related to the quality of the datasets, which could be missing information such as details about the socio-demographic profile of the population. Some of the datasets had self-reported measures which aren't always reliable, or had clinical measures that could be different in other regions and health systems, which might reduce the accuracy of the predictive models if they were applied elsewhere. Another limitation was that alternative AI techniques could yield different results, because most studies only used 5 or 6 different algorithms, and there are many available and more being developed all the time. The retrospective nature of the datasets was another limitation, because they may not accurately reflect future events, and COVID is probably a good example of that. And then a few studies mentioned that healthcare professionals still needed to interpret the results of any AI predictive model to ensure the results were clinically relevant, and that nurses should have assisted more with testing, implementing and evaluating the AI-based technology. And again, more examples of those studies are in the published review. And then finally, there weren't that many risks associated with AI reported in the studies, which was surprising, but the ones that were included a mix of ethical, legal and social risks, such as the perception that AI could replace nurses and other professionals or be used to supersede clinical decision making. There was also a concern that nurses lack knowledge and skills in AI, and that this was a risk to its future development and use in healthcare. And a few other studies noted the lack of transparency in how some algorithms work, which is often referred to as black box AI, which could cause safety and trust issues. And then a few studies highlighted the costs involved in gathering and analysing digital datasets versus the benefits we might get from using them, because AI is very expensive, it's not a cheap solution, and we don't know if it's cost effective or not yet. But overall, there was very little reporting of the risks of artificial intelligence. And again, more examples of those studies are in the published review. As our systematic review didn't cover all the limitations and risks of artificial intelligence, there are some good reports from the World Health Organization, the United Nations and other agencies that go into a lot of detail about the ethical and governance issues to do with AI. And I've added some of them on the slide. So algorithmic bias is probably the biggest problem with AI at the moment, and it's not actually an issue with artificial intelligence itself, but with the quality of the data sets that are used to train AI models, and the lack of thought that sometimes goes into analysing digital data, because AI is only as good as the data set it is based on. So if certain aspects of people's socio-demographic information is missing, or certain populations of patients are overrepresented or underrepresented in the datasets used, then the predictive model that is built is just going to reflect that. And there's already several examples of gender bias, age bias and racial bias in healthcare and other areas of society that are being exacerbated by the use of artificial intelligence. So some key findings for the nursing profession from our review are that firstly, nurse leaders should strengthen capacity in the workforce to collect good quality digital patient and administrative data to ensure that key nursing datasets are available to develop AI tools. This might mean advocating for more technical infrastructure such as electronic health records and mobile ways of working to collect data at the point of care, although there is a significant cost involved in doing that because it's not cheap or easy to do. Secondly, nurse practitioners ought to seek opportunities to develop, implement and evaluate AI-based technologies to determine their clinical utility and collaborate with colleagues in computer science and other disciplines to do that. Nurses can also become involved in AI governance to ensure these computational techniques are applied appropriately and vulnerable patient populations are not disadvantaged by the use of predictive algorithms. Our fourth recommendation then is for nurse educators to create curricula on artificial intelligence and integrate this into existing teaching programs so that students and practicing nurses get the knowledge and skills that they need to lead and participate in AI initiatives in healthcare. And finally, nursing scientists should conduct interdisciplinary research, examining if AI-based technologies are effective in improving patient and other outcomes to strengthen the evidence base in this emerging area. And we should also explore in depth the limitations and risks of AI to help minimise any negative impact it may have, including the impact on nurses' workload and workflow, and how to go about implementing AI-based technologies or digital tools in various clinical settings. So our review had some limitations, mainly that we didn't search the computer science or engineering databases, which would definitely throw up more studies. And we didn't do any critical appraisal because we were short on time and the research studies were quite technical in nature, as I mentioned. So the strength of the evidence base isn't clear, but hopefully the review is a useful summary of AI in nursing. Although we are in the early days of AI in nursing, it's a bit further along in medicine. Artificial intelligence is definitely here to stay. So as nurses, we need to get more involved. I think the take-home message from our review is that we need good quality digital patient and administrative data sets and a lot more informatics expertise in the nursing workforce in education, research and clinical practice so that we can work with colleagues in computer science and other fields to test AI algorithms and, if they're effective, implement AI-based technologies to improve patient care and professional practice. So I've been trying to work on some of the recommendations from the review over the last year or so, which is where the AI Nurses Network came from, to help support nurses who want to do clinical research on AI. As well as a dedicated website and monthly newsletter you can sign up for, we also have a suite of free educational resources on AI and data science to help nurses learn the fundamentals of artificial intelligence. So the training covers topics like machine learning, natural language processing and more to give nurses the knowledge and skills that they need to understand and apply AI in clinical research to improve professional practice and patient care. There's an existing online training program called Innovation Scholars that covers all the essential AI and data science topics you'll need and was specifically designed for healthcare professionals. If you follow the link on the training section of our website, you'll be directed to the specific courses and you can set up an account on the e-learning platform for free to enrol and work your way through the various online courses. This is a quick overview of the training that's provided, and there are more courses coming soon, like one on NLP and AI ethics. So you can pick and choose a whole range of things from how to code in Python to predictive modeling, machine learning, etc. If you are new to AI, then I'd recommend starting with the Demystifying AI course in Pillar 3. The courses are a series of self-directed videos that you can work through at your own pace, and there are some practical online toolkits to help you learn the more technical topics. So it's a great resource to have and will be really useful for nurses to get to grips with the fundamentals of AI. We also plan to run our own bespoke AI training as part of the AI Nurses Network, which will be specifically for nurses in the UK. And that will be hands-on and in person next year to help nurses learn how to access and clean a digital data set so it's ready for predictive modelling, how to choose appropriate algorithms to use, and then how to run and validate your AI model. Some machine learning colleagues at King's are going to help us run those workshops next year, so keep an eye out on the website and newsletter as we'll be advertising them as soon as they're organised. They will be based in London on our university campus for the moment, which I appreciate isn't great for nurses working in other parts of the country or further afield. But if the network goes well over the next 12 months and we can secure more funding to scale it up, then we hope to be able to run face-to-face workshops in different parts of the UK and globally in the future. The AI Nurses Network is also providing CCORN funding to support some pilot projects on AI in nursing, but this is limited to nurses working in the United Kingdom only. That funding call will be open on Monday the 6th of January 2025 with a closing date of the end of February. So that gives you roughly 8 weeks to apply and we would love to see as many applications from UK nurses as possible. If you have an idea for AI research in your area of clinical practice that you want to get off the ground, please do apply, and hopefully we can support as many nurse-led AI research projects as possible through that seed funding call. The application form will be available on the website from the 6th of January, and it's not overly long or complicated and includes the standard questions you'd expect around what is the existing evidence on the problem you want to address so that you have a clear background, what's your research question and study design, what methods are you going to use to collect and or analyse data, and then the impact of your research along with a budget, timeline and a description of the team. So it's very straightforward, there are no tricky questions, and we will also have a guidance document available that will describe the types of clinical research on AI that we're looking for, the amount of funding available, the closing dates, assessment process, etc. And they'll all be available from Monday the 6th of January. So if you're interested, please do apply. We hope to run a webinar as well, mid to late January, to go through all that and answer any questions you have about the seed funding call. And then finally, the AI Nurses Network will be promoting networking and other events from existing AI groups in the UK, like the Alan Turing Institute and King's Institute for AI, as well as running some of our own networking events to give nurses an opportunity to meet AI researchers and AI industry so they can get their ideas off the ground. Hopefully the network will go well over the next 12 months and we'll be able to get funding to keep it going and scale it up some of our activities. So we'd love for as many nurses as possible to join this clinical research network, and we hope you get lots of value from it. We're also very open to new ideas for the network and expanding it and improving it in different ways. So feel free to reach out to us on LinkedIn or via email. We've already applied for some funding to run a hackathon next summer focusing on AI and nursing as another way to encourage nurses to get their ideas for AI off the ground. And we're hoping to record a podcast series as well with nurses from all over the world that are doing AI research. We're not on any other social media platform at the moment other than LinkedIn because we want to keep things as professional as possible, and we're discussing setting up a Blue Sky account as lots of people are moving from Twitter to that. So if we do set it up, we'll post about it on LinkedIn and our website and newsletter. Before I finish, I want to say a big thank you to our funder, the Burdett Trust for Nursing, who's very kindly supporting the AI Nurses Network, and to thank our team. Besides me, there are several other colleagues involved, including Professor Rebecca Oakey, Dr. Karina Crossan, Professor Jackie Sturt, and our research assistant Richard, who just started with us. We also have a wonderful PPI member, David Woodcock, Dr. Susanna Bench is our clinical lead based at Guy's and St Thomas's NHS Foundation Trust, and Professor Emma Stanmore from the University of Manchester. So we all bring different expertise, which will hopefully make the network as successful as possible. So I know artificial intelligence might seem like the furthest thing from nursing, but it's not really. Historically, nurses have focused on hands-on care, and that will always be the core of what we do. But just like Florence, we need to use the data we collect on our patients to improve the care we deliver. And in the 21st century, the best way to do that is to collect data in a digital form and analyse it using AI and other computational techniques to understand and improve our practice and patient care. So thank you for listening, and I hope some of the webinar was useful for you. Feel free to drop us an email if you have any questions or want to follow up on anything, and you can find us online on our website and LinkedIn. Finally, all the references used in this webinar are on the last slide if you'd like to follow up on anything.